Chemotherapy, or the treatment of cancer, is all about combination therapy. And that combination therapy is basically dependent on using a combination treatment of drugs that have non-overlapping toxicities, that act on different parts of the cell cycle, and basically have different mechanisms of action. Often acronyms are used to talk about or to mention the combined regimens of the anti-cancer drugs. Now, despite immense efforts, lung neoplasms account for the largest percentage of cancer deaths in both males and females, followed by a high incidence of breast and prostate cancer. So we try to use a curative or palliative approach to the treatment of cancer patients, and that consists of surgery, radiotherapy, chemotherapy, gene therapy, and immunotherapy. Combined modalities may be used. Often we refer to adjuvant chemotherapy, which basically means removing microscopic lesions that may be left behind after surgical resections. Naturally, the goal of this therapy is to kill the cancer cells. The unique thing about cancer cells is that they differ from regular cells that do not undergo apoptosis. They do not undergo programmed cell death. Unfortunately, they undergo unchecked, unregulated, and ongoing proliferation. The anti-cancer drugs exploit this exact phenomena. However, it is unfortunate that due to this exact reason, you have the hallmark toxicities of the anti-cancer drugs, which is neutropenia, thrombocytopenia, alopecia, and immunosuppression. The resistance is also a problem, and usually these cancer cells are in a large necrotic core, protected away, and with a non-diffusional capillary network to which drugs cannot get to. The tumor growth once it becomes already advanced when it is of sufficient size to be detected. Greater than 2 cm, approximately greater than 10 to the raised to the 9 cells, and 10 more doublings would produce approximately 10 to the 12 cells in a mass of 20 cm in diameter. The kill ratio refers to a given dose of a cytotoxic drug destroying a constant fraction of the malignant cells. So basically, you go by a 1 log kill cycle, a 2 log kill cycle, and a 3 log cycle. The compartments of a solid tumor is also dependent on exactly which part of the cell cycle they're going through. DNA synthesis occurs in the S component. Pre-mitosis happens in the G2 component. Mitosis and cell division happens in the M component. GO is referred to as the quiescent or resting phase, and G1 is where you synthesize all the machinery for DNA synthesis, means DNA polymerase, DNA gyrase, and so forth. Different drugs act on different parts of the cell cycle. Your alkylating agents, anti-tumor antibiotics, nitrosurus, and cisplatin act in the GO phase. The anti-metabolites act in the S phase. They act as false metabolites. And the Vinca alkaloids, such as vincristine and vinblastine, act in the M phase. And etoposide basically acts in the SG2 phase. Now, the whole idea here is to destroy DNA. So primarily, these drugs are preventing cell division with no specific effect on invasiveness. They damage the DNA cells, they cause DNA intercalation, they cause scission of DNA strands, and as a result the DNA falls apart. The cancerous cells are still considered to be host cells that show unregulated diffusion, so one has to exercise caution. The chemotherapeutic drugs are then broken down into 2 other groups. CCS, which is cell cycle specific, which means that they act on a particular part of the cell cycle, and then cell cycle non-specific, often referred to as CCS drugs. Okay. The principles of action of cytotoxic anti-cancer drugs are well outlined in this slide here, and we've broken it down to anti-metabolites, alkylating agents, the cytotoxic antibiotics such as doxorubicin and daunorubicin, the anti-tumor antibiotics, and the Vinca alkaloids. The general toxicity of the chemotherapeutic agents is associated with nausea, vomiting, diarrhea happens with all the anti-cancer drugs. Bone marrow suppression may happen, and immunosuppression may happen, and one has to be very careful to titrate the dose of the drug to avoid neutropenia and thrombocytopenia. One of the last things you want for patients on an anti-cancer drug is for them to develop infections. And the cardiotoxic drugs will cause severe cardiotoxicity. These are the cytotoxic antibiotics, and they can augment and exacerbate congestive heart failure and cause delayed congestive heart failure as well. The first one are the alkylating agents. Now, the mechanism of action of the alkylating agents in a nutshell is that all your alkylating agents have a reactive alkyl group. This reactive alkyl group forms a covalent bond with DNA, and as soon as it forms a covalent bond with DNA, this causes scission of the DNA or the strand breakage. Cisplatin has the ability to go and bind directly into the guanine component. As a result, this destroys the DNA and the DNA falls apart. And the typical examples of the alkylating agents is cyclophosphamide, cisplatin, carmostin, chlorambucil, those, and procarbazine. Now, the resistance that happens to the alkylating agents basically happens due to increased DNA repair enzymes, a reduced permeability and lack of the drug to be able to reach the cells, and increased production of glutathione, which basically conjugates the drug. Neurotoxicity may also happen, leading to nausea and vomiting. Patients may develop delayed thrombocytopenia and alopecia. Sterility, and busulfan particularly is associated with pulmonary fibrosis and hepatotoxicity. Cyclophosphamide is activated in the liver, and one extremely problematic side effect of cyclophosphamide is that it causes serious hemorrhagic cystitis. The reason it causes serious hemorrhagic cystitis is because it releases a metabolite called acrolein, and acrolein is responsible for the hemorrhagic cystitis. This is usually treated by giving the patient mesna, which is the methyl ethyl salt or sodium sulfonate, and that basically traps the acrolein. The nitrosoureas basically inhibit the DNA cross-linking activity. They do undergo non-enzymatic conversions to the active compound and are highly lipid soluble. Procarbazine is a prodrug that is metabolized by the liver to its azoxy metabolite, and to note that procarbazine also is a monoamine oxidase inhibitor, therefore may cause unwanted food reactions, particularly with tyramine containing compounds. Cisplatin and other platinum analogues basically complex with the DNA. Cisplatin particularly will bind directly to the guanine component. They will cause nephrotoxicity and ototoxicity and are usually indicated for solid tumors, testicular, ovarian, bladder, and lung cancers. Carboplatin is a second-generation platinum analog and has replaced cisplatin because it has less nephrotoxicity and GI toxicity compared to cisplatin, and myelosuppression is usually a dose-limiting toxicity. Methotrexate and the antimetabolites. Now, the way the antimetabolites are classed, they are structural analogs of naturally occurring metabolites within the body. As a result, they will compete with the endogenous metabolite and will interfere with the cellular process. These drugs are for the most part, are mimetics of nucleotides. And basically, methotrexate is one of the first line ones. Now, methotrexate is structurally related to folic acid. It will competitively inhibit dihydrofolate reductase and therefore prevent the generation of tetrahydrofolate. Tetrahydrofolate is an essential factor for synthesis of both purines and pyrimidines. As a result, methotrexate inhibits both purine and pyrimidine synthesis. It is generally used in the treatment of acute lymphoblastic leukemia and non-Hodgkin's leukemia as well. It is a folic acid antagonist, so folic acid depletion may happen, causing neuropathy and paresthesias and peripheral neuropathy, and therefore patients must take supplemental folic acid. Mucositis may happen and it may cause bone marrow depression along with nephrotoxicity. The purine antagonist 6-mercaptopurine. 6-mercaptopurine is basically also considered to be a structural analog, and it is first converted to a pseudopurine nucleotide that will inhibit the first step of purine biosynthesis. These drugs will also inhibit the conversion of the purine precursor, which is inosinate, to adenylate or xanthylate, which is the precursor of guanylate. As a result, you end up with dysfunctional RNA and DNA synthesis. The toxicity is associated with myelosuppression, immunosuppression, and hepatotoxicity, and is often indicated for acute lymphocyte leukemia. 5-fluorouracil, on the other hand, is a pyrimidine analog, and it gets converted to a pseudopyrimidine nucleotide, and it will then inhibit the enzyme thymidylate synthetase. As a result, DNA synthesis will become impaired. It is basically used for solid tumors, and it is sometimes used topically for some malignant skin conditions. It may cause nausea, diarrhea, mucositis, bone marrow depression, and alopecia as a side effect. The plant alkaloids, which are the vinca alkaloids, are often referred to as the mitotic spindle inhibitors. These include specifically vincristine and vinplastin. To note of importance is that vincristine is one of the anti-cancer drugs that has minimal or almost no immunosuppression as well as a side effect. They will inhibit the polymerization of microtubules, they will inhibit the synthesis of microtubules, and as a result they will halt or slow down cell division, leading to cell death. The resistance that happens with the vinca alkaloids usually is to upregulation of P-glycoprotein, which will increase the excretion of the drug out of the cell, or the movement of the drug out of the cell. The adverse effects, basically alopecia may happen, local cellulitis, and basically they're hepatically eliminated, so one has to exercise caution in hepatic dysfunction. Vinblastine may cause painful ulceration if extravasation occurs, and myelosuppression, and will cause, actually both the alkaloids may cause gastrointestinal problems. Vincristine may cause myelosuppression and neurotoxicity, and it may also cause the symptom of SID-ADH, a symptom of inappropriate antidiuretic hormone secretion. Vinblastine often indicated for Hodgkin's breast cancer, testicular cancer, vincristine in all Hodgkin leukemias and Wilms tumor, and vinorelbine in non-small cell lung cancer and in breast cancer. The anti-tumor antibiotics, these are considered to be cytotoxic antibiotics. The cytotoxics are extremely toxic to the cardiac system. Bleomycin binds to reduced iron and basically intercalates DNA. It may cause serious pulmonary fibrosis and also mucocutaneous reactions that often involves palms of the feet and hands, and myelosuppression and alopecia. They are usually indicated for Hodgkin's, testicular, head, neck, and cancer. Dactinomycin, on the other hand, will inhibit topoisomerase II and cause intercalation. It may cause bone marrow depression, is indicated for pediatric tumors. And mitomycin basically is metabolically activated to an alkylating agent that cross-links DNA. And the adverse effects here is thrombocytopenia, anemia, and mucositis. The general principles are combined drugs with different toxicities or non-overlapping toxicities without decreasing the dose. For example, methotrexate combined with vincristine, and this will also reduce the likelihood of developing resistance. Cisplatin, bleomycin, and vincristine, particularly vincristine, are bone marrow sparing agents, and the resistance generally happens to reduced accumulation, increased secretion of the drug out of the cell via P-glycoprotein, reduced inactivation, increased concentrations of target enzymes that will break down the drug, and increased DNA repair enzymes, particularly DNA topoisomerase, and